Next, we go on to the next speaker, Dr. Gana Ajoy. She is going to talk about ischemic optic neuropathy. She is working as a senior vitreoretinal surgeon in Dr. Rani Menon's Max Vision Eye Hospital, Thrissur. Over to you, Dr. Gana.
Good afternoon. So my talk today is ischemic optic neuropathy, and I'll jump right into it. So ischemic optic neuropathy is infarction of any portion of the optic nerve from the chiasma to the optic nerve head, and it is a microvascular ischemia, and it is acute in onset. So when we look at ischemic optic neuropathy, it can either be anterior or posterior, and how do you distinguish that? The presence of disc edema points to it being an anterior one. It can be arteritic or non-arteritic, and absence of disc edema can point to a posterior, which can be arteritic, non-arteritic, or perioperative. So anterior ischemic optic neuropathy refers to ischemia of the optic nerve head, and posterior or PION refers to ischemia of the posterior optic nerve. In terms of blood supply, if you look at the optic nerve head, it is primarily supplied by the PCA, or the posterior ciliary circulation arteries. So it is basically a segmental distribution. This causes a sectoral blood supply to the optic nerve head and explains a segmental visual loss in AION. Embolic disease is rare. This is because of the small size and the extensive anastomosis of the vessels that supply the optic nerve head. Whereas a posterior ischemic optic neuropathy has no specific location, any part beyond the ONH up to the chiasma, and there is no specific definite artery to pinpoint. So let's get into a case. A 50-year-old gentleman, he presented with defective vision in the left eye of 2 weeks duration. Vision is 636 in the left eye and right eye is 66. He's a known hypertensive. The right optic disc has minimal cupping and it is a disc at risk. And the left shows a segmental disc edema. It is hyperemic. There is dilatation of the superficial disc capillaries. So normal visual field in the right eye and altitudinal visual field defect in the left eye. No CT shows swelling of the peripapillary RNFL in the region, in the inferior region without macular involvement. This is non-arteritic AION. This is greater than 85% of all cases. It is an idiopathic process, around 60 years, but can be younger than 50. Primarily a clinical diagnosis. Anterior to the lamina cribrosa, so we have to see disc edema, and occurs in small crowded disc or disc at risk. If the patient is very young, has glaucoma, has a bigger cup disc ratio, there is no REPD, there is cupping after an episode, and there is no disc edema, it cannot be NAION. Look for another cause. If there is too much of everything, that is disc edema or exudates or hemorrhages or even fluid, it is not NAION. So it is basically a compartment syndrome where the ischemia of the ONH from the hypoperfusion leads to edema, obstructs axoplasmic flow, again leads to edema, and then causes further compression of the circulation. It's a vicious cycle. The established risk factors are hypertension, diabetes, hypercholesteremia, optic disc morphology, and perioperative visual loss. And the late findings include disc pallor and corresponding nerve fiber thinning and macular ganglion cells loss. This is seen on OCT. FA shows initially a poor filling of the disc and the peripapillary choroid with late focal leakage. Primarily, as I've said, a clinical diagnosis, all the others are just contributory. If he has a typical risk, typical history, nothing else other than management is required. If they are atypical, further workup is required. So that includes ESR, CRP platelet counts, MRI, ocular imaging, and if younger than 50, also look for hypercoagulable states. There is no medical or surgical treatment. Aspirin does not help. Corticosteroids reduces the edema fast, but no significant visual gain. Bevacizumab again reduces the disc edema, but no visual gain. And optic nerve sheath decompression has no role. So no consensus also on the percentage of cases that will deteriorate or improve. So coming to the next case, which is a 68-year-old lady who presented with defective vision of the left eye 1 week onset. Visual acuity 360 in the left eye and right eye was 160. She has a mild headache but no eye pain. Has an altitudinal field loss. The fundus shows a pallid, severe disc edema. Small hemorrhages near the disc margin are there, not seen very well, but it is there. And the fundus photograph, as I've said, demonstrated this, and the angiogram shows a optic disc leak with patchy filling of the choroid. OCT again shows RNFL edema. ESR is 60 elevated, CRP is elevated. Considering a temporal artery biopsy at this stage, unfortunately at this point she has an ASOM, she has a mild fever. We are waiting 24 hours at this point. Beyond 24 hours, we've started on IV methylprednisolone, continued on oral steroids. She did well, but visual improved to 612, but disc has gone for pallor by that time. So this is a case of arteritic AION. So GCA, until proved otherwise, it is almost always associated with GCA. It is more widespread. There is no examination feature to rule out GCA per se, but the stakes of missing this are very high because the fellow aisle will get involved within days even. Stroke, aortic dissection, myocardial infarction are other life-threatening complications. There are criteria: age greater than 50, new headache, temporal artery tenderness, elevated ESR, and biopsy. Visual loss is the main thing. It mostly AION and arteritic is the most common cause. Headache is the most common symptom, and jaw claudication is the most specific symptom. Elevated ESR and CRP are seen in 85% sensitive for the presence of GCA, but 10% may have normal values. The gold standard is a positive temporal artery biopsy. MRI and Doppler ultrasound help us, but they are not definitive. Management is steroids, 3 days of high-dose IV methylprednisolone, continue with oral treatment, tapering over 1 year slowly, and now we have tocilizumab, which is FDA approved for GCA. Coming to posterior ischemic optic neuropathy, unilateral or bilateral neuropathy of vascular origin, no disc edema, disc appears normal, RAPD is present. In patients who have undergone, it occurs in patients who have undergone prolonged, especially spinal operations. As an uncomplicated complication of GCA, it can occur. And in a non-arteritic form, it is usually associated with vascular risk factors. It is hard to identify, but it is always a diagnosis of exclusion. You have to do all the investigations, rule out arteritic causes, rule out other compressive lesions, but there is no therapy as such. The key is limitation of risk factors and treatment of GCA. Now coming to this particular gentleman, who is a 51-year-old gentleman with best corrected visual acuity of 6.6 in both eyes. Defective vision, came to us with defective vision in both eyes. Diabetic of 10 years duration. And this is the picture. He has both eye disc edema, sectoral in both eyes. It is not very well seen in this particular image, but the FA, as you can see from the right eye, initial hypoperfusion with late leak and even perifoveal leaks, macular leaks. This was in 6th May. The left eye also showing a sectoral or a segmental disc disc edema with late leaks, far more on the left eye. He also has associated new vessels. So this is both eye NAION with HRPDR in both eyes. This is on 8th May. He undergoes PRP in both eyes. Then 2 months later, he has drop in vision in both eyes. Right eye has dropped to 6.6 parts N8 and left eye to 636 N24. The disc, and now there is macular edema as well. This is after 2 months of treatment. That is laser. And he was given injection of Avastin in the right eye on August 19th and left eye on 26th. By October, his vision has come back to 6.9 in the right eye and left eye 6.6. And this is what the fundus looks like. There is the presence of membrane because there was NVD along with this. In both eye, there is epiretinal membranes, and this has become pale. Left eye sectoral, right eye, a great proportion of the disc is involved, disc pallor. So diabetic papillopathy. What is diabetic papillopathy? It's presumed to be the result from diabetic microangiopathy, and this theory is supported by abnormal disc surface staining and fluorescent leakage found on FA. There are no pathological studies to confirm this theory. So is it NAION? Is it not NAION? The tug of war goes on. I consider it part of ischemic optic neuropathy and treat it as such. So to conclude, NAION is the most common non-glaucomatous optic neuropathy in patients older than 50. No proven treatment to improve visual outcomes. Arteritic AION is a medical emergency, and nearly all are due to GCA. Thank you.
Thank you, Dr. Ghana, for those discussions on dilemmas in ischemic